I'd like to call the meeting to order of the Minnesota Senate Health and Human Services Committee. It's Thursday, March 13th, 2025, and we do have a quorum present. Our first bill on the agenda is Senate File 1682. Senator Maye Quade.
Thank you. Good morning, Madam Chair, members. Before you today is Senate File 1682. This bill puts into statute a policy adopted by DHS in 2023 to not screen into child protection families who cannot safely bring their child with a serious mental illness home due to lack of services. Despite this policy being in place since 2023, NAMI Minnesota and the Ombudsman for Mental Health and Developmental Disabilities continue to hear from families who are being referred to child protection. These are families that are engaged with and love their children, but their child's needs are very complex. Several have been adopted out of the child protection system and thus have experienced severe trauma. They have placed their children on waiting lists for residential treatment, applied for CADI waivers, and much more. But the wait lists are long, and it's very hard to find people to work with your child when they have extreme behaviors. Just because a family is referred to child protection doesn't mean that these services become available. They won't, because they don't exist. Referring these families to child protection because they cannot have their children discharged from the hospital can put them at risk of losing their jobs and custody of their other children. With this bill, we are ensuring that families are not penalized while finding support for their children and doing what's best for their family. And today I have two testifiers with personal experience and Sue Abderholden from NAMI.
Senator Maye Quade, I do see an A1 amendment. Is that an author's amendment? Yeah. Senator Boldon moves the A1 amendment. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The A1 amendment is adopted. And yes, please proceed. Ms. Abderholden, are you first? Okay.
Yes, thank you, Madam Chair. Member Sue Abderholden, Executive Director of NAMI Minnesota, and we strongly support this bill. I have personally taken calls from numerous parents who have been placed in this situation. They have a child with complex needs, often symptoms that are aggressive, a child who is homicidal and suicidal. Their needs simply cannot be met at home. They can't keep their child or other family members safe. And we're not talking about simple depression or suicide attempt. We're talking about children who are so dysregulated or with histories of extreme trauma that they are lashing out, throwing objects, trying to physically hurt their parents or siblings. They are brought to the ER, and if they're lucky, they're admitted. And then when the hospital wants to discharge them and the family doesn't believe they can keep them or other family members safe, and they refuse to take the child home, they are threatened with being reported to child protection. Despite the fact that they have placed their child on every wait list that exists for intensive services or residential treatment, despite them desperately calling every agency they can find to ask for help. I want to make it very clear that we are talking about highly engaged parents. They are not neglecting their children. The system is. We simply do not have enough services and supports for these children. They have not abandoned their children. They are desperately seeking services for them. They love them and are fighting for them, but there is so little out there that can help them. These stories, frankly, have left me in tears and honestly angry at the system. Not only do the hospitals not need, frankly, to threaten and then report these parents to child protection, but clearly under the current screening policy, counties do not need to screen them into child protection. We've heard hospitals tell us that counties tell them the only way to get services is through the child protection door. And yet we have the Children's Mental Health Act, and some of these families already have a children's mental health case manager. For over 20 years, we have worked to separate out our children's mental health system from child protection, and yet here we are. To make it clear, child protection does not have a magic wand. They cannot make these services just suddenly appear. By putting these families in child protection, you're threatening their jobs and their ability to keep their family together. Families have been told their other children could be taken away. If they work with children in another setting, they risk losing their job. I understand that hospitals are frustrated by having these children in an ER or in a bed, but referring these families to child protection simply does not solve the problem. Because the screening guidelines are being ignored, NAMI adamantly believes that we need to put this language into statute. I urge you to support this bill. Let's not make it harder for families. Thank you.
Thank you. Ms. Wood, please state your name for the record and begin your testimony.
Madam Chair, members of the committee, my name is Michelle Wood. I live in rural Goodhue County with my husband of nearly 22 years and the 4 of our 5 children who have not yet graduated. I'm speaking to you today about my funny cat, duck, and 4-H loving daughter whose smile can light up a room. She came to our home the week of her first birthday and is known for her giant dimples. She has struggled with feelings of depression, suicidal ideation, and self-harm for years. She was in kindergarten the first time we carried her out of a store screaming that she wanted to kill herself. She has diagnoses of ADHD, impulse control difficulties, depression, learning disabilities, and reactive attachment disorder. 2024 was a rough year with multiple psychiatric hospitalizations, as well as a 10-day stay at the Southeastern Minnesota Regional Crisis Center, or CIRC, after assaulting me and one of her sisters, an incident that scared her. After her time at CIRC, she started a new medication. We changed therapists to one who did animal-assisted therapy and EMDR, and we began to see progress. Then, on December 8th, my husband David was diagnosed with stage 4 pancreatic cancer, and the bottom fell out of our world. On one of the coldest days in January, she ran out of the house with no coat and no shoes. My 11-year-old son followed his safety plan and locked himself in his room while her sisters and I ran after her. They caught up with her first, putting themselves between her and the road. She then started assaulting them, even grabbing one of her sisters by the throat and choking her. I caught up with them just as this happened and managed to pull her away. She then ran into our field, where she lay unresponsive for nearly an hour on the frozen ground until the sheriff's deputies finally convinced her to go into the house. She was taken by ambulance to the hospital and then again to CIRC. While at CIRC, she had inappropriate and assaultive behaviors and was taken by ambulance to the hospital and then transferred to an inpatient adolescent psychiatric unit. We worked with our children's mental health case manager and our insurance company to get her approved for residential care at Girard in Austin, Minnesota, but it would be a few weeks before she could be admitted. Then the hospital called and said we needed to take her home, despite the fact that she was saying she was still afraid she would hurt others. We begged doctors, nurses, and the hospital social worker to help us find a safe place for her to go until she could be admitted to Girard. Our county social worker applied to a shelter in the cities, but there wasn't a bed. Our health plan advocate spent hours on the phone with us trying to find other options, even a bed at another hospital, all to no avail. Over the next several days, we fielded multiple phone calls from doctors threatening to report us to child protection. I had called NAMI, so I had the screening document saying I shouldn't be screened in, but I also knew it wasn't a guarantee. On Monday night, CIRC refused to admit her again because she had endorsed homicidal ideations in her interview. Tuesday morning, I was sitting with my husband during chemotherapy. Rather than spending precious time with him, I was frantically speaking with our social worker and health plan advocate, still trying to come up with a plan for her. That's also when I received the call from the psychiatrist telling me that they were making that child protection report. We told her that we'd be over once we finished in the chemo clinic, and we brought our daughter home that day, despite our better judgment, but at least we'd gotten through chemo. We have faithfully cared for our daughter's special needs for years, but this time we knew she needed more than we alone could do for her. Shockingly, even with all the begging for help we did, the only discharge advice from the hospital was, if she gets aggressive and hurts someone, call 911 and press charges. And this past Monday, 21 hours before she was admitted to Girard, that is exactly what happened after she assaulted her best friend at school. My daughter deserves better care than let the justice system deal with her. The rest of my family deserves to feel safe. We've put key locks on all the bedroom doors. We've added motion cameras to record the interior and exterior of our home. We've added driveway alarms. We clearly are not neglecting our daughter. We tried desperately to get her the treatment she needs. Our choices were to be charged with neglect and fight that battle while fighting cancer, or risk the safety of our entire family. And all of you here today have the opportunity to change that for the next family, and I beg you to do so. Thank you for your time.
Thank you, and thank you for sharing your story with us. Next online, we have R.G. Manolis. If you can please state your name for the record and begin your testimony.
Madam Chair, members of the committee, my name is R.G. Manolis. Since 2008, I have adopted 5 children out of foster care, 1 as a single parent, and 4 with my spouse. My spouse and I are also legal guardians of our grandson. Since 2014, we have cared for about 15 people, many of whom still rely on us for support. This is our calling and the greatest honor of our lives. I'm here today to talk about our son. He came into our lives at age 7 as an emergency foster care placement in the middle of the night. Once he settled into our home, he was curious about the world, eager to learn new things. He loves to explore the outdoors. He's deeply spiritual and always wants to help others. We supported reunification until that was no longer an option. We were honored that both his family and his tribe agreed for us to become his adoptive parents. His adoption day when he was 10 was one of the happiest days of my life. We love him more than I could ever put into words. As we advocated for our son and established cultural, mental health, educational, and other supports for him, we learned that in addition to his complex trauma, he had a rare genetic disorder that would affect his physical health and his cognitive, social, and mental health functioning for the rest of his life. One of the symptoms of his complex trauma and his genetic disorder is sudden violent outbursts. Despite a great support team and every possible intervention, and believe me, we have traveled all over the state and tried many different options, we have been unable to stop these from happening. To make a long story short, there have been dozens of visits to a school and our home, many assaults against many people, and many visits by police officers, always followed by a trip to our local rural ER. The ER always quickly discharged him. Eventually, we began waiting until he was calm after an incident and driving him 3 hours to an ER in the Twin Cities, where he would be more likely to receive the mental health services he needed. After 1 or 2 weeks in the ER, he'd be transferred to a mental health facility for another 2 to 3 weeks, then return home. And this pattern happened over and over until the mental health facilities in the Twin Cities refused to take him again. In 2022, we made the most difficult decision of our lives. When an ER in the Twin Cities could not place him and discharge him, we refused to take him home. What followed was a daily call to our local CPS for nearly 2 months. We were terrified. Both of us could have lost our jobs, and my spouse could have lost her nursing license. We were most worried about who would care for our children if they were taken from us. All of them have complex trauma and many needs that we have spent most of our time with them, all of our time with them, trying to support them. Our local CPS luckily understood the situation and never opened a case against us, but as the weeks wore on, it was difficult to trust that there would ever be an end to his stay in the hospital. After about 2 months, he was admitted to a brand new facility that serves kids with complex diagnoses. It was a miracle. The facility had everything he needed and supported our whole family's healing. But after 14 months, insurance refused to continue to pay for his stay, and he had to return home. From September 23 to September 24, I took a partial leave of absence from work to care for him. By this time, 5 different in-home care companies had refused to serve him, even though he had 40 hours of care available through his waiver. On Saturday morning, our son assaulted me after I stepped between him and our 5-year-old grandson. This had happened many times before. And as usual, the police transported him to the local ER, which would not hold him. This time, the police charged him and took him to a juvenile detention center 2 hours from our home, explaining it was the only way that they could think to keep our family safe. After 60 days, he received a Rule 20, and the judge ordered us to pick him up. For the second time, we refused. Then our son's attorney requested that a CPS case be open against us, presumably to ensure that he would get the help he needed and not end up stuck in the juvenile detention center without the services he needs. The judge agreed. And although our local CPS did not want to start a case against us, the judge was ordering them to do so. Again, we face all the same fears, loss of our jobs, and of course, most importantly, loss of our children. The CPS case has been closed because we reluctantly signed a voluntary placement agreement with the Juvenile Detention Center. We didn't feel we had any other choice. Our son is now 15, and he has a lot of the same qualities he's always had. He wants to help people. He wants to be outdoors, enjoying time outdoors, and he wants to spend time with his family when he's well enough to do so. He's been awaiting placement since mid-September. We visit at least once a week and talk to him daily, as we have every time he's been away from us. All of our visits and calls end with an "I miss you" and "I love you." We are very, very privileged and very lucky to have many resources available to us despite our rural location, and to be able to take time off work and travel to get other resources we need. We're lucky to have 2 very dedicated case managers, one who supports his mental health needs and one who supports his developmental disability. So far between them, they have contacted 102 different options for placement, all of which have turned him down. These include home care companies, group homes, residential treatment centers, and many other types of facilities. Mental health care in our state is made up of dedicated people who could not be working harder. We really have had an amazing team of support people. But especially for kids in rural areas and kids with complex needs, there is no adequate help. Even very privileged, very experienced parents like us could not find help for our son. We don't know how others are faring who do not have the resources we have. When a parent refuses to pick up a child at discharge from an ER or juvenile detention center, believe me, we are experiencing the most excruciating decision of our lives. We are not parents abandoning our children. We're parents desperately trying to keep ourselves and our children safe, and perhaps most importantly, desperately trying to get the help our child needs, help that has never been available in the 8 years we have cared for and loved him. Thank you very much for allowing me to tell my story.
Thank you, and thank you for sharing your story with us. Now I have Lisa Harrison Hadler. Welcome to the committee, and please state your name for the record and begin.
Thank you, Madam Chair, members of the committee. I am Lisa Harrison Hadler. I am the Ombudsman with the Office of Ombudsman for Mental Health and Developmental Disabilities. Our office has a statutory charge to promote the highest attainable standards of treatment, efficiency, competency, and justice for our clients receiving services for mental health, developmental disability, and substance use disorder. For many years, our office and myself personally have heard the heartbreaking experiences of parents desperately seeking medically necessary care for their children, but unable to access the right level of care and services at the right time due to the limited capacity of Minnesota's Children's Mental Health Services Continuum. Today, I am here to express my strong support for Senate File 1682 that codifies the changes that were made to the maltreatment screening guidelines in 2023 to explicitly state that when parents are actively involved in seeking care, but care is not currently available, that is not neglect. These are children with complex support needs, including aggressive behaviors and intense suicidality. They require sufficient services and supports to ensure their and others' safety. Unfortunately, for too many of these children and families, there are not providers currently willing and with the capacity to serve them. Many of these children have children's mental health or waiver case managers already actively involved and working on finding a placement option or a service provider that can meet the child's needs, only to receive denial after denial after denial from providers because the child's needs are too acute. We have also seen situations where children have been discharged from another residential setting due to their concerns about the level of need and concerns about maintaining safety despite having 24/7 staffing available to support that child. Other situations, a service provider or a treatment setting might be identified, but it is weeks or months until that admission date or service initiation date can begin, and children are stuck on lengthy waiting lists. These are all circumstances beyond a parent's control. It is certainly not neglect. Despite the updated screening guidelines, we continue to hear from families that are threatened into accepting an unsafe discharge plan with no services or supports or risk a report to child protection. We hear from parents with active child protection investigation and involvement simply because they advocated for their child's safety and care needs, refusing an unsafe discharge plan containing no actual services or supports due to provider denials and lengthy wait lists. Parents report feeling unnecessarily blamed and shamed by a process that does nothing to help identify a service provider with the willingness, expertise, and capacity to serve their child. We hear from counties and hospitals regularly that they do not consider the updated screening guidelines binding, but that they are simply guidelines. Senate File 1682 will change that by clarifying in statute that lack of sufficient capacity for children to have timely access to medically necessary care may be a systemic failure, but it is certainly not a parental one. Thank you for the opportunity to be here today.
Thank you. Next, I have Lawrence Dickens. Welcome to the committee, and please state your name for the record.
Thank you. Good morning, Chair Wicklund and members of the committee. I am not Lawrence Dickens, my apologies. My name is Nikki Conway. I am the Director of Children and Family Services in Dakota County. Lawrence is a colleague of mine. He got pulled away to do some other necessary child protection work this morning. So I have been practicing in the field of child welfare for the last 17 years. I've been in Dakota County for the last 3 months. Prior to that, have worked in both Ramsey and Scott counties. I am here on behalf of the Minnesota Association of County Social Service Administrators, otherwise known as MACSA, and I am one of the tri-chairs of the Children's Committee of MACSA. On behalf of MACSA, first of all, we'd like to thank the families who have spoken just before us. We'd like to thank NAMI and Senator Maye Quade for highlighting the need for services and supports in our state. We cannot underscore that point enough. That is the underlying issue that we are facing here today, is we have a lack of resources and continuum of care for children in the state of Minnesota, and specifically in Dakota County. My testimony today will focus on the screening process and the process for working with hospitals and families when children are boarding in hospitals or other settings due to these lack of system resources and system placements. And before I do that, I first want to comment on the amended language and thank Senator Maye Quade and other folks who worked on that amended language. We have had a chance to look at that briefly and are running that through the rest of our committee to get some more feedback on, but we appreciate the work on that amended language. Child protection is a serious and deep end systems response. Whenever possible, we prioritize community-based resources and voluntary services, and we aim to offer support before situations escalate to assist families to get the support they need to thrive without initiating a child protection response. We recognize that families are best served in the community with supports and services and with placement as a last resort. As you've heard before in testimony and probably in many other places, Minnesota is facing a critical need to access and address the barriers to services, supports, and placement. Those are the things that will limit the situations that we find ourselves in with children boarding in hospitals. Again, we cannot underscore that point enough, and addressing this issue from prevention to placement for the entire continuum of care will also need to ensure that we have the workforce needed to implement that and staff the services and supports. In Dakota County specifically, it is our practice to follow the Department of Children, Youth, and Family Screening Guidelines for all reports received related to child maltreatment. On behalf of MACSA, we would like to stress that the screening guidelines are best positioned to guide this work. These guidelines can be updated as needed depending on the dynamic nature of the work, depending on federal and state policy change, and the changing climate in Minnesota. We do this in partnership with the Department of Youth, Children, and Families. These guidelines need to be reinforced with training and processes. We do understand that. Like we heard in previous testimony, in situations where lack of service options or residential treatment beds lead to children boarding in hospitals, initiating a child protection response does not always solve for the underlying issues. Each situation and family is unique and dynamic. The families that you heard spoke earlier today demonstrate the complexity of each individual situation and the amount of stakeholders and service providers that are involved in those decisions. Rather than immediately initiating a child protection response in Dakota County, in order to respond to the complexity and uniqueness of each situation, Dakota County coordinates a rapid response consultation team for reports that come in related to these conversations. This multidisciplinary team approach allows us to quickly share information and collaborate between multiple systems and departments and to determine any and all available resources to best meet the needs of the children and youth. This could include assistance with systems navigation in a voluntary way, such as children's mental health or waiver services. Thank you again for the opportunity to testify on this important issue. In closing, MACSA supports the screening guidelines to continue to guide the practice in this area. And again, we are working on looking at that amended language, but we want to underscore that we allow enough flexibility to respond as needed based on each family's information and individual situation. Thank you.
Thank you. And last testifier, Danny Ackert. Welcome to the committee, and please state your name for the record and begin.
Thank you, Madam Chair and members. My name is Danny Ackert with the Minnesota Hospital Association. First and foremost, MHA is supportive of the ongoing efforts of this committee and the legislature to help fix the crisis of adolescents boarding in hospital emergency departments. We therefore support the underlying intent of Senate File 1682, which is to better support youth and families who are experiencing crisis. However, Senate File 1682 takes an oversimplified approach to some of, if not the most complex patient care needs that are intended to be addressed through specific responsibilities and processes that hospital workers, county workers, and patients and their families navigate together. Hospitals and health systems uniquely know firsthand the critical need for additional investments and policy improvements in our behavioral health system to ensure that the most appropriate and timely care is available in the correct care setting and with the correct care teams, especially for youth boarding and emergency departments. There is also no understating the importance of engagement with families so that our frontline teams can most effectively work directly with counties and other authorities to ensure that hospitals have the best information available to maximize the ability to appropriately find the right care for them. And as the number of youths boarding in EDs has alarmingly increased in recent years, hospital care teams have more than ever before had to closely work with counties to coordinate the extremely limited resources available to both support and protect patients, and to coordinate with their families and designated caregivers. The process for determining appropriate community placement for youth boarding in EDs not only differs county by county, it also necessarily differs patient by patient based on their unique needs and what their families desire and or agree to. We urge the committee to recognize that there is no one-size-fits-all solution here, as ED boarding may well present the most complicated care need today in our healthcare system. As the care teams in our hospitals work to navigate the community placement process, our first desire is to work with families and the county to search for the appropriate care outside the hospital. In many instances, the first point of contact with the county can be through Child Protective Services, or CPS, not because the hospital is reporting neglect or is erroneously defaulting to neglect, but because the current county process and the most efficient coordination of available resources dictates it. Despite this, we know that CPS is no guarantee and there is no magic here. Additionally, we know from our members that families often ask hospitals and their case managers to engage CPS from the outset of ED boarding to ensure that the full array of services is available services can be more timely accessed at the county if needed. This includes foster care, shelter, children's mental health services, and CADI DD waivers. In closing, we cannot more clearly state that the crisis of youth boarding in the ED is happening today, right now, and the hospitals are standing by not to only continue to be the place where youth behavioral health crisis is cared for 24/7, 365. Our members are deeply proud of that. There is no frustration on our end with that. And we are also standing to work with the counties, with advocates, with this committee and the legislature to ensure that the full process of establishing community placement is improved. Senate File 1682, when layered upon the current system, which sometimes does involve CPS, may end up delaying necessary support to youth in crisis and their families. Given the current crisis and the extremely limited resources available, we urge this committee to recognize the complexity and nuance needed to create positive change in the system, which is desperately needed. Thank you.
Mr. Ackert, I just question, did you form your testimony based on the original bill, or have you had a chance to review the amendment?
We are still
Mr. Ackert.
Thank you, Madam Chair. Thank you.
Sorry.
We are still reviewing the amendment and kind of going through our teams to discuss that, but I think it's a positive step.
Okay, thank you.
Thank you.
That concludes the testimony. Members, do you have questions or comments for the author? Senator Abler.
Thank you, Madam Chair. I'm sorry I was late. I missed some of the testimony, but I just want to speak up as a person who's tried to weigh into the whole child protection thing. In 2017, I never thought I'd be a chair again. We had like, whoa, okay. So we jumped into a bunch of topics, including child protection. I'm not sure, Senator Whitman, if you were a part of those conversations, but Senator Hoffman and I were, and others. And it is not a simple situation. And there were people at this meeting who I respected and appreciated who were yelling at each other, shrieking, literally, at this meeting. If anybody remembers being there, it was a sight. We should have recorded it, not to be mean, but just to show the great divide of opinions and how do we protect a child, and does a parent have a role, and who gets to. But I come out of that reminding us all, when it comes to child protection, maltreatment, we set the standards here. We tell the counties, and God bless you for what you do, and we tell the hospitals, we tell everybody, we define the standards, for better, for worse. And I won't go into some maltreatment stuff we did, which irritated the department, where we said, no, this is a bar that we're willing to accept as being a reasonable bar, where it was an innocent thing and self-reported. I react to with all respect, the lengthy parsed responses in writing to make sure that they get this all right. This is the bar we need to establish, that this is not a thing. And so we got the rapid response team, we're gonna go study it. This parent doesn't need to meet with a staffer that they don't have enough of already. And so in this discussion, we were told several years ago, that there's like 3-6 months of training, and then finally they decide. There's not enough human beings, and so in 2 weeks, the green staffer is now deciding to screen a case in, and as time moves on, to permanency within 6 to 12 months. Like, holy buckets. And the parent of this child who is in this situation is already doing the best they can, and they're beside themselves of what to do, and now they can't find a place, and now child protection's there because they can't find a place, and they did the right thing to take him to the hospital. So, to the world out there watching this, would you please help us find a way to draw a line that's a safe line, and this is that safe line. The word in the amendment on line 2.11, it says solely because they can't find somewhere to go. You don't got to get your team going for this. You shouldn't even get a team going for this anyway, but we're going to make it easier. So you don't got to do a team. So if I could even add on to the bill, I would like that, Senator. So this needs to happen, and it needs to, if we only do one thing this year, let's do this. Thank you.
Senator Boldon.
Thank you, Madam Chair. I don't have a question, but just a very brief comment. Thank you, Senator Maye Quade, for working on this. Thank you to the families, the testifiers who spoke today and shared your stories. Clearly, our systems are failing you, and we can't continue that way. We shouldn't. And I have no doubt that this is, complicated, and maybe there's no easy answers, but this seems like definitely something that we should do. To hold parents who are in extraordinarily difficult situations that, it's hard to even imagine, to put ourselves in those shoes, to put them in a place where, they're being, saying that they're neglecting their children when that is absolutely the opposite of what you are doing, is something that we should not continue. So thank you for this work. Thank you, Madam Chair, for hopefully we can move this forward.
Thank you. Any other, Senator Kupec?
Thank you, Madam Chair. Probably more of just the same sentiments expressed by Senator Abler, Senator Boldon, and thank you, families that testified on this. This is like the ultimate catch-22. You're trying to do the right thing for your kid, and you're penalized by trying to do the right thing for your kid. We know that there's just not enough beds, and people are backed up in hospitals, and there's no place for them to go. And we, I have personal friends that this has happened to, the same thing, and they're trying to do the best for their kid, and the system is letting them down, and then to have the system come after you and say, you're not a good parent, thank you for bringing this bill forward. This is, I think, we have to fix this now.
Thank you. Yeah, I'll just add, I know this has been a work in progress for a number of years. 2 years ago, I worked with Ms. Abderholden brought to me this issue, and we tried to get something put in place, and I think it may have helped, I don't know, but it also continued our discussions about this, so I'm really happy that you're bringing this forward this year. But it just does seem like something that we need to set, a standard, and we need to figure out then, what is it that is getting in the way of it being implemented or followed, if there are things. I mean, we know that we need to continue to work on expanding access to the correct facilities for all children, and we will continue to do that. But for these situations, it seems like the standard should be in place, and it should be something that can be followed. So, Senator Maye Quade.
Thank you, Madam Chair, and I really appreciate the comments from the committee. This is addressing a really, really awful problem that has been created, but the other problem that's part of that too is the lack of beds, and that's, it's part of this, but it's also a separate bill, and I think that this testimony today really shows that it demands our action as well. But I really want to thank Ms. Abderholden and the families and the counties and the hospitals for meeting too to kind of work on this language. There's been a lot of work on this, and I'm kind of carrying it across the finish line here, but whatever we can do to support these families, because like Senator Kupec said, sending the system after you when the system's already failed you is just wrong.
Thank you. And so, members, this bill needs to move to the Judiciary Committee. So Senator Boldon moves that Senate File 1682 as amended be recommended to pass and be referred to the Committee on Judiciary. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The motion does prevail, and Senate File 1682 as amended is passed to the Committee on Judiciary.
Thank you.
And our next bill on the agenda is Senate File 1732. Senator Boldon. Senator Boldon. And I do show that you have an author's amendment.
Yes, Madam Chair, I do. It just adds some eligibility requirements.
Senator Boldon moves the A1 amendment. All those in favor, please signify by saying aye. Aye. Any opposed? The amendment is adopted. Senator Boldon.
Thank you, Madam Chair and committee members. I am pleased to be before you with this bill that would allocate funding to the Family Supportive Housing Grant Program. We know that housing ends homelessness. Interventions like family supportive housing break the generational cycles of homelessness through appropriate and comprehensive care for the whole family. The goal is to fill a critical funding gap around family supportive housing. Modeled after the Homeless Youth Act, this would create flexible funding for comprehensive family-oriented services. Supportive housing provides non-time-limited housing with rent subsidy and services in the building for individuals and families transitioning out of homelessness. Family supportive housing welcomes caregivers and children into larger units. It provides individualized services and care to all family members. This bill would fund service providers in family supportive housing to care for children and caregivers holistically through age-appropriate, child-centric services for education and enrichment, career planning, work skills planning, job placement and employment retention, budgeting and money management, referrals for counseling, medical or psychiatric services or substance use disorder treatment, parenting skills training, self-sufficiency support services or life skills training, including tenant education, and 24-hour-a-day, 7-day-a-week on-site staffing. This is essential at a time when we know that families experiencing homelessness is on the rise. And Madam Chair, I do have a testifier.
Thank you. And I have Ben Helvig Anderson. Please state your name for the record and begin your testimony.
Thank you, Chair and members of the committee. My name is Ben Helvig Anderson, and I am the Vice President of Policy and Organizing at Beacon Interfaith Housing Collaborative. Beacon owns and operates 24 affordable housing buildings, most of which are supportive housing. Supportive housing provides safe, affordable, and stable housing with on-site services. With the rise of families experiencing homelessness, Beacon is working to create over 200 family supportive housing units through 5 new buildings across the metro. These units will house over 500 kids and caregivers. 3 of those buildings are opening now. Of the around 5,000 supportive housing units in the state, very few are set up for families or are large enough to accommodate them. This is because programs like housing support and housing stabilization services support individuals, but do not have robust enough service dollars to accommodate a whole family's needs. We thank Senator Boldon for working on this bill to fill this critical gap for family supportive housing. When a family experiences homelessness, all members experience trauma, especially the children. Parents often have one or more undiagnosed mental health issue, and children have developmental and educational disruption. Family supportive housing is the essential multi-generational intervention that stabilizes a family through subsidized housing and on-site wraparound services for each member. This gives parents the space and tools they need to be healthy and succeed, and children the stability to grow, learn, and just be kids. Services like case management, age-appropriate kids programming, parenting and job training classes, school support, all help reground a family. Often families are separated because of homelessness, substance abuse, or domestic violence. Through the service providers in these buildings, we work with child welfare to legally reunite families and keep them together. This is a very tender and volatile moment that requires the specialized care of family-oriented providers. This pilot program would fill the critical state funding gap for these specialized services and demonstrate the success family supportive housing can have. It would create the blueprint to continue funding this grant program far into the future for more families. Thank you for the opportunity to speak on behalf of this bill, and I hope you can support it.
Thank you. And now on Zoom, we have Alex Zozel. And I'm sorry if I mispronounce your name. Please, if you can state your name for the record and begin your testimony.
Hi, good morning. My name is Alexandra Zozel, and I live at the Vista 44, a family supportive housing building. Before I found Vista 44, I was a supportive housing counselor helping others find stability in difficult times. But like so many people, I faced major losses in the past few years. One of the biggest being the home that I rented for 13 years. We were forced to leave due to asbestos, and suddenly my 2 kids and I had nowhere to go. The options were heartbreaking. My son and I stayed at his father's house, which was not a safe environment, and my daughter had to live separately with her father, and I watched her mental health decline rapidly. As a mother, this was devastating. I knew I needed help. Then, when I reached out to the Domestic Abuse Project for coordinated entry, assessment. Not long after, I got a call from Violet at Vista 44 asking if I'd like to come see the place. Walking into Vista 44, I was amazed. It was brand new, incredibly secure, and the staff welcomed me with open arms. They went above and beyond for me and my kids. For the first time in a long time, I felt relief. My kids and I could finally be together again without fear, without instability, without the constant weight of survival on my shoulders. The biggest impact has been on my daughter. The first month we lived in Vista 44, she was hospitalized. When she was discharged, we made the decision that she would live with me full time. I set up her room when she was in the hospital, and I will never forget the joy on her face when she came home to her new space. Since then, she has made an incredible turnaround. Having stable housing gave her the foundation to heal, and I can say with certainty this has changed her life. For me, Vista 44 has given me the ability to breathe again. My next goal is to focus on my own healing and find a career that I love. But none of that would be possible without the stability of supportive housing. Not only have I personally experienced how family supportive housing has transformed my life, but in my years of support as a supportive housing counselor, I saw firsthand how it changed so many others' lives as well. I've seen families rebuild, parents regain their independence, and children finally get to the stability they need to thrive. Supportive housing is the solution to homelessness, and family supportive housing works. That's why I'm asking today to support this bill to fill the state funding gap for family supportive housing, because every family deserves a chance to rebuild, to heal, and to thrive. Thank you.
Thank you very much for providing your testimony today. Now, members, do you have any questions or comments for the author? Senator Abler.
Thank you, Madam Chair. This supportive housing thing has been around quite a while. Back in whenever it was, there was a pilot for Ramsey County in Blue Earth, and we were trying to collect data. Is it going to help or not? And so I'm glad it can expand. Madam Chair, there used to be this MAD department at MMB where they would do this ROI approach. This has an ROI benefit to it. But I'm tired of being a broken record, but there's certain things if you do, it's actually better and cheaper. And so unfortunately in your budget, you're going to find money to do this. And if you don't find the money, it's going to cost more and be worse. And this is one of those kind of programs. It's truly beneficial. The governor called me after that letter, and I said, hey, could you do some help? Can you talk to MMB and the EBOs and the LEBOs and talk about actually paying attention to this ROI business in a legitimate, not fake way to get us out of Dodge on this budget thing? This is one of those things, if you put in $1 million, you're going to save 3 or something. And a little more and you save a little, it tops out. And he said he didn't know if he could do that. I said, well, come June 20th, you're going to really want to be doing that. And so if there's some way that this project, as one example, could help us with some ROI numbers, otherwise, to help us promote that behind the scenes. As I mentioned on the previous bill, we write the rules about who we decide. We tell when the counties, no, that's not something to worry about. This is something to worry about. We draw a line. And at the end of the day, we in government write the rules about our budgeting rules. And the governor has quite a bit of authority in that as well, in a friendly way. And I think that we can take advantage of the challenges in our budget to actually do things better. And maybe when the dust settles, even given the big deficit, that we could actually have a system that works more seamlessly for people. So I don't know how else we're going to do it, except just doing continuing resolutions and put off any decisions. So anyway, so if the promoters of this could just come up with some of that, that'd be awesome. Thank you, Madam Chair.
Thank you. I don't know, Senator Boldon or Mr. Helvig Anderson, did you have any comments to that? Or?
Thank you, Madam Chair. Thank you, Senator Elliott, for your comments. I agree. I mean, this is a program. If we, provide the resources, make investments here, it absolutely does pay for itself down the road. I'm certainly willing to look into ways to, add that into our budget to show that, we don't currently have a, dynamic budgeting system, but it's worth working on for sure, because there are many spaces where that is the case. This is certainly one of them.
Thank you. Senator Port. Senator Port is online today. Senator Port.
Thank you, Madam Chair. Thank you, Senator Boldon, for bringing this bill. Our supportive housing entire system across Minnesota is really in a dire position. We've been working on this in the Housing Committee for several years, but it is such a complex system with different agencies involved, and the money that's needed to run both the housing side of this, but also the services side of this is so complex. And we are already seeing, we saw just yesterday, $1 billion cut from the federal government that will cancel work that many of these housing providers needed to do to update and keep up their units. we need sort of an all hands on deck approach when it comes to supportive housing, really fully funding the services as well as the housing side, or we are going to lose these providers. And this is not an easy, sort of industry to get into and to provide these services. So if we lose them, those will be supportive units that will be gone from Minnesota. They're not just easily going to get picked up somewhere else. And that would be, as Senator Abler said, a much more expensive, really detrimental policy choice for us to make. And so I think this bill is really, really important. I appreciate you bringing it, Senator Boldon. I think it is a necessary part of the conversation. But it is only one piece of the conversation, and we need to keep having that full conversation in all of our committees.
Thank you. Any other questions or comments? Not seeing any. Senator Boldon, any final thoughts?
Thank you, Madam Chair, and thank you to the committee for considering. There is, I'll note, a one-page or a handout in your packets I would direct your attention to. It's estimated that nearly 5,000 Minnesota families with children experience the trauma of homelessness any given night. This is a need in every corner of our state. Yesterday was Homelessness Day on the Hill, and so members, many of you probably had visits from folks in your districts talking about this. I did as well. I had a room full of folks from Rochester, and one of their messages to me was there are not resources for families experiencing homelessness, and there is such a need, and this fills that gap. And providing those services really helps people, as I want to thank Alex for her testimony. As she said, every family deserves a safe, stable place to heal and thrive. And so this helps families to do that. So thank you.
Thank you. Yeah, I appreciate your bringing the bill forward. It does seem to fill a need, and we will be laying it over. Senate File 1732 as amended is laid over. Thank you. And next we have Senate File 2022, Senator Kupec. Senator Kupec, I see you have an author's amendment.
I do. I have the A1 amendment.
Senator Kupec moves the A1 amendment. All those in favor, please signify by saying aye. Aye. Any opposed? The A1 amendment is adopted. Senator Kupec.
Thank you, Madam Chair. Thank you, members of the committee. We have heard today a similar testimony about the lack of beds and facilities, and this is also the case here with PRTFs, juvenile psychiatric treatment facilities. You'll see in your packet there is a map showing where existing PRTFs are within the state, and there is nothing up in the northwest corner of the state. We are taking some of our kids, we are shipping them off to places like Arkansas for treatment. We do not have enough of these facilities within our state. So the county that I live in, Clay County, seeing the need for this, has stepped up and is going to build a PRTF. Originally thought about building a brand new one standalone. Cost of that was rather prohibitive, but they do have a non-secure facility that they can easily actually move over and convert to a PRTF within an existing facility. So they're going to try to do that in a way to save a little bit of money, but still meet that need. So if you look on the map too, there's shaded in, there are 28 counties that have passed resolutions of support for this. So this is not just a Clay County thing. This is a whole northwest part of the state, and even working down into some of the suburbs of the Twin Cities, that this will provide services for a much larger part of the state. We are in a unique situation, I think, within our community to house this, because we are in a metropolitan area of about 265,000 people. We have 4 colleges, universities within our community. We have the workforce that will also be needed to staff such a facility, that has been kind of a hindrance for other ones that have tried to pop up around the state. So we are asking for some money from DHS to move with this, and there's also a few things in here about changing per diem rates as well, and again, an appropriation for the county for funding this PRTF. And with that, Madam Chair, I have two Steves with me today to testify.
Welcome to the committee, and Stephen Larson, if you could state your name for the record and begin your testimony.
Thank you, Chair Wickland, members of the committee. My name is Stephen Larson. I'm the administrator at Clay County. I am here with Stephen Summers from Solutions Behavioral Health. And on behalf of Clay County, and as Senator Kupec mentioned, several counties in Minnesota, I would like to thank you for the opportunity to testify in support of Senate File 2022. There's an alarming shortage of psychiatric residential treatment facilities, or PRTFs, as we've heard today in Minnesota, particularly for children with high acuity, complex and or co-occurring conditions. This gap is critical as severely impacts the state's ability to support vulnerable children and specifically their families who are in need of the specialized treatment. According to the Minnesota Star and Tribune article in October 2024, the Department of Human Services data revealed that 281 children were referred for placement in the state's 4 existing PRTFs. However, only 66 of those children were admitted, despite facilities being licensed for 150 children. They were only serving 85 as of June of 2024, as reported by Aspire Minnesota. This data underscores the urgency increasing the state's capacity to provide care for children facing significant behavioral and mental health challenges. Clay County recognizes the pressing issue and is actively working to address it. Clay County has invested over $175,000 into pre-designs for facilities and have been proud to have Solutions Behavioral Health on board to lead the accreditation process and oversee the delivery of services. We have worked with the legislature to adjust and shift from a funding perspective in hopes of making this more of a likely project to happen. This initiative has garnered support from a broad coalition of stakeholders. I believe in your package you have the map that Senator Kupec addressed. And just again, please note the gap that you see on the side of the state. While this facility would serve all of the state of Minnesota, the challenge that we face in our region is that we have families that are going 2.5 to 4 hours. And as you've heard in previous testimony, the impacts on that family is very challenging. We know that success in children's programming comes with our ability to have family involvement and engagement. And so, again, in addition to the counties, we have 11 tribes that are supporting this resolution, are supporting through resolution, and we've worked with key legislators. Senator Kupec, Senator Hoffman have toured our facility, and along with agency commissioners to ensure the facility aligns with state broader goals for mental health care, and we've received bipartisan support to this point.
Thank you very much. Mr. Summer, please state your name for the record and begin your testimony.
Good morning, Madam Chair and members of the committee. Thank you for having us here today. Again, I'm Steve Summers. I'm the Director of Grants and Special Projects for Solutions Behavioral Healthcare Professionals. Solutions is a 501c3 nonprofit mental health agency. We are committed to making a difference in the lives of individuals struggling with mental health and behavioral problems. Solutions began in 1999, and we have offices throughout North Dakota and Minnesota. We currently employ about 310 employees. Opening and operating a psychiatric residential treatment facility, or PRTF, comes with substantial financial challenges, especially when it comes to maintaining a sustainable per diem rate that covers the costs of operations. Many facilities across the state have faced difficulties staying open due to financial instability, and without a sufficient and sustainable per diem rate, it becomes nearly impossible for these essential services to remain operational while providing the high-quality care children and complex mental health needs require. Currently, the costs of providing care in PRTF can often exceed the available reimbursement rates that's leading to deficits that force facilities to close their doors or reduce the services. This challenge is particularly pronounced given the extensive and specialized care that the children in these programs need, including therapeutic interventions, skilled staff, and appropriate facilities. The Minnesota Senate File 2022 directly addresses this issue by addressing the following. Adequate compensation for high-quality care. The $1,800 per day per diem would provide the facility with the financial resources necessary to support specialized treatment programs and skilled staff, ensuring the children receive the best care possible. Covering remodel and operational costs. Operating a PRTF involves substantial costs, accreditation, and licensing costs, including staffing, facility maintenance, therapy, and medical services, and other essential resources. I believe you have a document that identifies proposed costs of facility operations. It's just a snapshot of some positions that we are required to have. Again, those operating costs does not include the schooling, the lease, the utilities, transportation, insurance, ongoing training and recruitment of staff, the medical documentation software, and when working with these children with high behaviors, sometimes it does have some substantial property destruction and costly costs repairing those. Senate File 2022 would also provide funding to remodel the existing non-secure detention space into an 18-bed PRTF to ensure licensing compliance with DHS and MDH. On October 24th of last year, DHS officials toured the non-secure programming area. During the tour, DHS inquired our willingness to provide a portion of the beds to become a locked unit, which we would support. If that is a need of the state, we would be willing to do that. And again, we want to ensure accessibility by ensuring the facilities are financially viable. Senate File 2022 helps keep PRTFs open, which is crucial in addressing the current shortage of treatment options for children facing significant behavioral health challenges and improving long-term outcomes. Financial stability allows facilities to focus on improving treatment outcomes for children with adequate resources. Facilities can provide comprehensive care plans, cultural sensitive programming, and long-term recovery support to children in need.
Thank you. Members, do you have any questions or comments? Senator Abler.
Well, thank you, Madam Chair. Certainly it's a good idea to try to do this. We're a little brokish. Can someone explain to me, I see there's some cash in the grants, I get that, but can somebody explain to me the mechanism about taking the $200,000? Where does that get applied in the bill?
Senator Kupec, do you want to speak to that?
Sure. Thank you, Madam Chair. Senator Abler. So the $200,000 takes out and gets reapplied kind of later into the other years so that it can carry on out into the future. If that's the correct assumption I have.
Senator Abler.
Well, the grant is used to help plan these facilities. Is that the point? I mean, you're not building ongoing. I'm more confused with your answer than I was before I got it. So,
Madam Chair, Commissioner Abler, or Senator Abler, excuse me.
Mr. Larson.
Sorry. Yes, when DHS came through the facility, we are going to have to make some minor adjustments to the facility. Be making a portion of it secure. There's going to be about $600,000 to $700,000 in remodeling that would happen. And then when the facility opens, based on the figures that Mr. Summers provided, you do not receive funding from DHS until your accreditation is there. And so, as you can see through your document, Solutions is going to be looking to have to upfront about $1.5 million before they start receiving any funding back from the state once they get the accreditation.
well, thank you.
Senator Abler.
I don't know if we're going to have any money to do this anyway, so it may be irrelevant, but it's good to call attention to this. And frankly, given the whole 48-hour rule and everything, that's just a disaster in the whole, we talked about in the Human Services Committee, where we're putting people in jails that should be in places that are scattered around. This is, I think, better than building $300 million jails in Wright County. But so I don't need to spend much time on it. But this is a popular source of money. Apparently, Senator Maye Quade has taken some of the same money. So you'll have to do like this sort of thing. So thank you, Madam Chair.
Thank you, Senator Abler. Any other questions or comments? Senator Kupec, any final thoughts?
No, thank you, Madam Chair. Thank you, committee. I just want to, I commend my county too for just stepping up to take on this challenge. I think we are just in a unique situation to be able to provide these services.
And it does definitely look like there is a need. So thank you for coming to testify today, and we will lay over Senate File 2022. So Senate File 2022 as amended is laid over. Thank you.
Thank you.
Next, we have Senate File 1953, Senator Mann.
Madam Chair.
Senator Abler.
While she's coming up, but this, I appreciate repurposing existing money. And I imagine you've already asked the question, but I'm not in those meetings. But is there some way that DHS could get us a list of grants that have not gone out the door yet, or that could be interruptible, or like repurposed in this way is for the committee so we can look at that? I presume you've asked that question already.
Yes, Senator Abler, we did last year, and that's how we were able to obtain some additional funding that went towards other projects. We asked that question and received some answers, and yes, we will definitely do that again this year. So.
Thank you. And could that be provided to us as well?
Sure.
Thank you. Much obliged.
Senator Mann.
Thank you, Madam Chair. Members, Senate File, what number are we? 1953 is a bill that we worked on with the Mental Health Legislative Network, and it does many things. It allows for the continuation of audio-only mental health care. It expands access to case management. It increases the rate for protected transportation. It provides grants for early episode of bipolar disorder programs, which is much like the first episode of psychosis program, and it expands the first episode of psychosis programs. With that, Madam Chair, I'll pass it along.
Senator Mann, I do show an author's amendment.
I do have an A.
Okay.
One.
So, Senator Mann moves the A1 amendment. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The A1 amendment is adopted. Senator Mann, you wish to move to testimony?
Yes, Madam Chair.
Ms. Abderholden, please state your name for the record again and begin.
Thank you, Madam Chair. Member Sue Abderholden, Executive Director, of NAMI, Minnesota. I just want to highlight a couple of the items in the bill that won't be covered by other testifiers. Case management is a low-cost service that can really help people with serious mental illnesses stay connected. Right now, people with PTSD, anxiety, panic disorders, and eating disorders do not qualify. And they should when these illnesses actually significantly impact their lives. We understand that there is a cost to the county since they pick up the non-federal share, but case management frankly can prevent the use of more costly services. I really want to point out especially PTSD and trauma PTSD, which really can significantly impact people's lives, and case management can really help them kind of move on and recover. We also made some other changes to the case management law. We want to be able to connect people when they've been committed within the last 5 years instead of the last 3 years. Again, kind of expanding that population a little bit, especially for people who have been committed, to make sure that they're staying engaged with services. And then the other thing that happens also is that when people get better, then they're like, well, then they don't need case management anymore. But what they often need is case management to stay better. And so if the mental health professional feels that they need to stay connected with case management, we would allow that to happen. I want to say that audio-only telehealth has been extremely helpful for people with mental illnesses. Often they don't have smartphones. It might be difficult to access the internet, and especially with things like therapy, you can do that over the phone. And so for people who are very low income, they might even be homeless, to be able to stay connected to their therapist is really important. We've also suggested a rate increase for protected transport. Protected transport was added to non-emergency medical transportation quite a few years ago as a way to provide an alternative to transporting people in crisis. Instead of using an ambulance or police, we could actually use this type of vehicle. Unfortunately, we only have about 3 vehicles in the state that are being used, and we know that if we would just increase the rate a little bit, we could have more, and especially for rural Minnesota, not having those kind of vehicles like ambulances off the road, driving, long distances, this is a great alternative. In the amendment, we moved a section from one bill to another, and that is to make sure that when residential treatment facilities are doing their existing training on medication, that they include the signs and symptoms of tardive dyskinesia. That's one of those illnesses that you can't actually turn back. It's a side effect of a lot of antipsychotics, but if you catch it early, you can make sure it doesn't progress anymore. So we just wanted to name tardive dyskinesia in there. There are two other programs in the bill, early episode bipolar and psychosis, but I will let the next testifier speak to them. Thank you, Senator Mann, for bringing this forward.
Thank you. And next, I show Jules Lindholm. If you could please state your name for the record and begin your testimony.
Great. Madam Chair and members of the committee, I'm Jules Lindholm, a licensed independent clinical social worker at the Health Fairview Psychiatry Clinic at the University of Minnesota. I'm here to support this bill, especially sections 4 and 5, which focus on establishing early bipolar programs and sustaining early psychosis programs. These services are absolutely crucial for our community. As both a program director and a clinician, I've seen firsthand how much we need early intervention for bipolar disorder and psychosis. You can reference a fact sheet that you have that's provided by NAMI about first episode of psychosis. But in summary, Navigate is a comprehensive treatment program for individuals experiencing their first episode of psychosis. Think of it as a one-stop shop for outpatient mental health care for therapy, medication, family support, assistance with school and work, and peer support. Currently, we have 6 first episode of psychosis Navigate sites across Minnesota, thanks to DHS funding. But despite adding these new programs, referrals to the university's early psychosis programs keep rising. We had 192 referrals in 2022, trending upward to 283 referrals in 2024, and that's just our program alone. With the demand we're seeing, it's critical that you continue supporting these programs. Right now, patients with bipolar disorder do not qualify for the DHS-funded early psychosis programs. However, a few years ago, our state funded the development of an early bipolar disorder intervention by adapting the Navigate model. But here's the catch. We got the funding to develop it, not actually to run it. So in October 2023, the U of M and Health Fairview launched a pilot program, which is called STRIDE. We support a small group of people with early bipolar disorder, and it's already shown its value. But sustaining this program and providing timely access to care will remain a significant challenge without the proper funding. Expanded funding for early bipolar disorder would allow us to use the same effective methods as Navigate and respond promptly and effectively to those in need. Imagine a young person whose life has been turned upside down by the sudden onset of extreme symptoms like mania and psychosis. They've lost their job, they've spiraled out of school, and their world is falling apart. This isn't just a story, but it's a reality for many of the people who come to our programs. Our programs are a lifeline for these young people to reclaim their futures. I want to tell you about one of our clients who gave me permission to share their story. For a condition like bipolar, which can flip and twist a person's mind faster than you can imagine, it's essential to have the knowledge and skills for daily management, especially when it's your first time experiencing these thoughts and feelings. He said that the STRIDE program has provided him a much-needed stability through his senior year of college. And he goes on to say, "I'm so glad that I found this program, but finding it wasn't easy. I was lucky when others are not." Right now, we have 10 people waiting to begin our services. And when we have a waiting list, people with active psychosis are expected to hold out. People with early bipolar disorder are turned away. People are knocking at our door begging for help. But let me be clear, these programs work, and we have the research to back it up. They help people navigate their symptoms and find their stride again. First episode psychosis services have become a staple in the Minnesota mental health community, and we have the infrastructure to deliver early bipolar services just the same. A yes vote on this bill will reduce delays in treatment for early bipolar disorder and psychosis, expand services, and improve outcomes for young people and their families. Thank you for your time, and I'm happy to answer any questions.
Thank you. Next, I'd like to call up President Robert Larson. Welcome to the committee, and please state your name for the record and begin.
Mohamed, hello, my relatives. Chair Wickland, Vice Chair Mann, committee members. I'm Robert Larson. Most folks call me Deuce, but at this time I'm the president of the Lower Sioux Indian community. And as that capacity is how I'm testifying today. Lower Sioux Indian community in the state of Minnesota, a sovereign and federally recognized Indian tribe, supports Senate File 1953 as amended. This bill includes a revision to Minnesota statutes, Section 246.462, Subdivision 20, for broadening the eligibility for targeted case management and community support services to include complex post-traumatic stress disorder. This would include someone who has post-traumatic stress disorder symptoms that significantly interfere with daily functioning related to intergenerational trauma, racial trauma, or unresolved historical grief. The current eligibility for these critical services does not take into consideration impacts of historical trauma, and therefore individuals with PTSD related to such trauma are not eligible. Targeted case managers play an important role to assess and address significant impacts of the health of the people they serve, and this legislative change would ensure they have access to this care. Indigenous people have experienced trauma from war, death, stolen land, broken treaties, suppression of their spiritual beliefs, forcible removal of children from the families, tribe and culture, and systematic racism. Federal Indian law and policy during the removal, reservation system, allotment and assimilation and termination eras are documented painful chapters in U.S. history. Indigenous people have also experienced high rates of out-of-home placement in child welfare proceedings as a result of various state practices and federal policy designed to destroy the Indian family's core and connection to their tribe, including their language and culture. It also stems from federal policy on boarding schools. Despite the First Amendment freedom of religion guarantees, Indigenous people were targeted for punishment when they practiced their religious beliefs. In 1978, Congress passed the Indian Child Welfare Act and the American Indian Religious Act. Yet intergenerational trauma, racial trauma, and unresolved historical grief continues to affect many of our people to this day. As recently as 2022, the U.S. Department of Interior acknowledged the intergenerational trauma caused by federal boarding school policies. The community's mental health case managers frequently come across intergenerational trauma, racial trauma, or unresolved historical grief as a basis for patient mental health concerns. Since 2023, 43% of adults seeking mental health services in coordination with our mental health case managers were due to these mental health concerns. Your support of this bill would help mental health targeted case managers support Minnesota's medical assistance population on their path toward healing. The community also supports the revision that accommodates continued case management or community support services for adults so they can maintain their recovery. And I urge the committee to support Senate File 1953. Padam Yado, and thank you.
Thank you very much for coming to testify today. Next, I have a testifier on Zoom, Anna Solom. If you could please state your name for the record and begin.
Yes, thank you, Madam Chair and committee members. My name is Anna Solom, and I am the Director of Case Management for Aspirus St. Luke's in Duluth. I have been a registered nurse in the acute care setting for 16 years, and I am with you via Zoom today in support of Senate File 1953, specifically to provide additional reimbursement for protected transports for trips over 100 miles. We want to thank Senator Mann for bringing forward this proposal. Protected transport providers who are Medicaid contracted have become an increasingly scarce resource, with one of the main reasons being that Medicaid payment rates currently cover only 1/3 of the costs required for basic operations. This gap makes it financially unfeasible for these agencies to contract with Medicaid. As a result, acute care hospitals are forced to shoulder the cost of these payments to maintain patient flow, reduce emergency department boarding times, and create access to care for those desperately in need of emergent medical and psychiatric intervention. In addition, the lack of protected transport often creates discharge delays from acute psychiatric units to alternative levels of care, further limiting inpatient psychiatric beds for those in need. Supporting this bill will provide a critical boost to the viability of the protected transport safety net. Protected transportation is essential for safely moving the most psychiatrically ill patients we serve. Without adequate protected transport, the responsibility for patient movement is diverted to ambulance services at a higher cost while detracting from their ability to provide life-saving care to patients experiencing medical emergencies in the community. I have seen this catastrophic impact to patient lives in my career. The financial burden of this issue has already had a significant impact on Aspira St. Luke's. For fiscal year 2024, our hospital paid over $100,000 in uncompensated secure transports for our Minnesota residents with Medicaid coverage, and nearly $250,000 overall for uncompensated transportation at large. Compounded by the ongoing shortage of acute psychiatric services, patients are often transferred across the state to find an available psychiatric bed where appropriate treatment can be provided. Protected transport is the backbone for these patient transfers, often ranging well over 100 miles. If this service remains underfunded and ultimately unviable in its current state, the financial burden will continue to shift to hospitals, emergency department boarding times will increase, and patient outcomes will deteriorate as a result of the trickle-down effect. In conclusion, it is imperative that we provide this small but essential additional level of support for protected transport reimbursement. The gaps in the services available to those in need of mental health services are wide. However, this small component will help maintain access to care, patient flow, ensure appropriate access to Medicaid benefits, and allow patients to receive life-saving care. Thank you for your consideration, Madam Chair, and thank you, Senator Mann, for this proposal.
Thank you. And then I'm wondering if MAXA has a representative who wants to testify. Welcome, Mr. Freeman. Please state your name for the record and begin.
Madam Chair and members of the committee, thanks for the opportunity to testify. My name is Matt Freeman. I'm the Human Services Policy Analyst for the Association of Minnesota Counties and the Executive Director for the Minnesota Association of County Social Service Administrators. Counties greatly appreciate the goals laid out in expanding eligibility for mental health case management and the other aspects of this bill. Mental health case management is an important and effective service to support people with mental illness, particularly amidst our continued mental health crisis. Counties share the goals of the author and advocates in the need for better support for access to mental health services. It's one of the top priorities of the Association of Minnesota Counties this year is creating a comprehensive mental health continuum of care and expanding that. We support a number of aspects in the bill. However, counties have concerns about the expansion of eligibility under the new proposed definitions in the original bill's Section 2 and the ability to successfully implement that expansion. This bill redefines mental illness in this section and potentially significantly expands eligibility by redefining persons with serious and persistent mental illness in several ways. Counties have a couple of significant concerns related to this. First, the increase of volume for those who may be eligible for the service raises some questions as to whether our current workforce and staffing could reasonably absorb the added workload and manage caseloads. We've reached out to DHS for technical assistance, looking to project statewide how many new eligible folks this bill would potentially cover. The second is that the cost burden of this new eligibility would be borne by county property taxpayers. Case management is not funded by the state. Counties pay the non-federal share of case management through Medicaid. And this bill creates an expansion of that entitlement service and would include covering the costs for individuals who are not enrolled in the MA who are seeking the service as well. We do have a significant amount of case management population that is still not yet enrolled in MA, meaning the counties can't bill for that federal portion of this population either. Originally, I will note that the non-federal share for this type of case management was paid for by the state, and we would encourage, if the intent of the author and the legislation is to move forward with expanding this eligibility, counties would encourage an amendment to the bill so that the state takes on the non-federal share of the cost for this new group and their eligibility. Or that the bill determines a state funding source to reimburse counties for that cost of serving this additional population. Particularly in the midst of other human service cost shifts that have been proposed by the administration and potential impacts to Medicaid funding at the federal level, counties have concerns about an expansion of eligibility and the new costs this would put on local property taxpayers. We know that active discussions in Washington on several major proposals to reduce federal Medicaid budgets are going on, and we caution that there may be additional risks at this time to expanding this Medicaid entitlement. We're committed to continuing to work with advocates and the author on this bill and appreciate the goals. Thank you.
Thank you. That concludes the testimony on the bill. Members, do you have any questions or comments? Senator Kupec.
Sure. Thank you, Madam Chair. Thank you, Senator Mann. I guess I would, I do worry about shifting costs down into our counties that would also be shifted on there. I will also say, though, that the transportation part of this, having worked on the rural ambulance thing, the transportation part, this is so necessary because those transportations tie up ambulances all across the state, particularly in rural areas, and then that relies on other ambulances to backfill them, and there's a workforce shortage there. So I think anything that we can relieve on that front, also good. And I also like the fact of removing the sunset on the telehealth, the audio-only coverage too, which I also think is a really important component. So there's a lot of things in this bill I really do like. I do worry about some of the cost shifts onto the county, but I think it's a move in the right direction, though. So thanks.
Thank you. Any other questions or comments? And Senator Mann, is that something that you're continuing to have discussions about, where the costs would be borne, and do you have any feedback on that?
No, conversations we are still having, Madam Chair. Absolutely.
Thank you. Any final comments on the bill? No? Seeing none, this bill needs to be referred to the Committee on Human Services because of the non-emergency medical transportation component. And so Senator Mann's motion is that we recommend that Senate File 1953 as amended do pass and be referred to the Committee on Human Services. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The bill does pass, and Senate File 1953 as amended is referred to the Committee on Human Services. And next we have on the agenda Senate File 2134, Senator Mohamed. Oh. And I understand that there is an author's amendment that's being passed out right now. Senator Mohamed, this is an author's amendment. Senator Boldon moves the A1 author's amendment. All those in favor, please signify by saying aye. Aye. Any opposed? The A1 amendment is adopted. Senator Mohamed.
Thank you, Madam Chair. It's good to be back in this committee. Senate File 2134 is a very straightforward bill. It simply changed the term emotional disturbance and serious emotional disturbance to mental illness and serious mental illness throughout Minnesota statutes. These terms were coined many years ago because people thought it would be easier for families to hear emotional disturbance versus mental illness. But the term emotional disturbance is often confused with the special education term emotional or behavioral disorder, which is not synonymous with mental illnesses. This bill does not change the definition or criteria of emotional or serious emotional disturbance in the Children's Mental Health Act. The second change is an attempt to continue to separate the children's mental health system from the child protection system. The term out of home placements is used in child welfare to refer to children placed out of the home due to abuse or neglect. In the Children's Mental Health Act, this is not the reason children are leaving their homes. They are often receiving more intensive treatment. So instead of out-of-home placement, we want to use the term residential treatment or therapeutic foster care to relay the fact that children are accessing treatment. While this is a really big bill, there are just the term shows up in many parts of our statute, Madam Chair, and what I have with me, Sue, with NAMI.
Welcome, Ms. Abderholden.
Thank you, Madam Chair, members. Sue Abderholden, Executive Director of NAMI, Minnesota. And as Senator Mohamed pointed out, this is a very straightforward bill. During my over 20 years at NAMI, Minnesota, I've seen a great deal of confusion between the terms emotional disturbance and emotional or behavioral disorder. They are not the same, but they sound the same. Parents whose children fall into the emotional or behavioral disorder category of special education sometimes think that their child has a diagnosis of a mental illness or are falling into the emotional disturbance category under the Children's Mental Health Act. But they haven't, and in fact, if you Google the term emotional disturbance, you almost always come up with an explanation related to special education. Parents of children are no longer afraid of using the term mental illness. They know exactly what that means. They know what depression and anxiety are, so let's not shy away from using the correct term. For decades, NAMI Minnesota has worked to separate out the children's mental health system from the child protection system. You know, decades ago, families actually had to relinquish custody to the county in order to obtain residential treatment. That changed, but families still have to go through the child protection system, but could agree to a voluntary placement, meaning they at least retain decision-making over their child's care, but still had to file papers with the court. More recently, we created the third path so that families don't have to go through the child protection door at all. But unfortunately, as you know, the rate for room and board was set so low that families are still today having to go through child protection to access residential care for their children and endure relative searches and committees making decisions about their child. I want to thank Senator Mann for carrying Senate File 1561 that would actually increase that rate. So the second change is to replace the term out-of-home placement, which is truly a child protection term, and use a more accurate term, residential treatment or therapeutic foster care. Some might wonder why the bill couldn't have just instructed the revisor's office to change out these words, but we learned it didn't quite work that way. So I did spend time going through every single time it was used in statute to make sure that we were changing it to the correct terms. Thank you for the opportunity to testify today, and I'd be happy to answer any questions.
Thank you. Members, do you have any questions about the bill or comments? Well, it seems pretty straightforward, Senator Mohamed, and it does seem like work that we should be doing to make sure the language is clear and that we keep it up to date. Do you have any final comments on the bill?
Thank you for hearing this, Madam Chair.
So Senate File 2134 will be laid over. So Senate File, Senator Boldon moves that Senate File 2134 be, as amended, be laid over. So, and our last bill on the agenda is also Senator Mohamed's bill, Senate File 2124.
Thank you, Madam Chair and members of the committee for hearing Senate File 2124, the Bridge to Shelter Act. I want to thank my co-authors, Senator Abler, Port, Marty, and Champion. Madam Chair, I also have the A1 amendment, which would put the bill in its most current form, if we can take that up.
Yes, Senator Mann moves the A1 amendment. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The A1 amendment is adopted. Senator Mohamed.
Thank you, Madam Chair. Yesterday was Homelessness Day on the Hill, and you likely heard from your constituents about the need to invest in housing and homelessness prevention. This committee's jurisdiction is all about human needs, and we can all agree that almost no human need can be met if a person lacks shelter and a place to call home. Today, I'm here to tell you that we continue to face homelessness crisis in Minnesota, and it is unacceptable that in 2025, any Minnesotan should lack a stable, dignified, and accessible place to sleep at night. The crisis may look different across our state, but the outcome is the same. People suffer, families suffer, and children suffer. Senate File 2124, the Bridge to Shelter Act, will advance our collective goal of ensuring that no Minnesotan experiences unshelteredness homelessness. A coalition of impacted groups, providers, and counties have endorsed this bill, Madam Chair. Senate File 2124 would establish 3 different buckets of funding. The first bucket is increasing the emergency services program. The second bucket would be for counties and tribes, and the third bucket would be county-to-county capacity building, where counties would share best practices and technical assistance to better leverage certain programs and funding streams. The reason for the 3 distinct buckets is both strategic and deliberate. providers still need access to ESP grant opportunities for their programming needs. And counties and regional continuum of care do not want to compete with providers for that funding. Rather than compete, we establish separate funding for counties and tribes. This bill provides necessary funding to counties, tribal nations, and homelessness providers. It could fund response, outreach, diversion, navigation, and housing-focused case management. The amendment you adopted incorporates additional feedback from our providers and advocates for the tribes and counties to ensure that there is maximum local flexibility in how these funds are distributed, and that we properly manage and that we properly engage and respect tribal nations and their role in homelessness response. Areas of the state that have scaled up these services have seen decreases in unhoused population. This bill invests in successful strategies. The financial model for the current system is not sustainable. Homelessness response overwhelmingly relies on local property taxes to fund it. Counties like mine, Hennepin, have been forced to increase their financial support because, frankly, there just aren't any other funds. Currently, local governments are the biggest funders of homelessness response in Minnesota, and we are proud of that. We also need the state's increased support and partnership. With proper state help, we can end this crisis and make homelessness in Minnesota rare, brief, and non-reoccurring. And with that, Madam Chair, I'd like to bring up the testifiers so you can hear from them today.
Thank you. Yeah, and first we have Mayor Jacob Fry. Welcome to the committee. Welcome, and please state your name for the record and begin.
Good morning, Chair Wicklund, members of the committee. My name is Jacob Fry. I'm the mayor of Minneapolis, and I'm proud to be here in support of Bill 2124, which is the Bridge to Shelter. I want to give a big thank you to Senator Zainab Mohamed for her work on it, and thank you to all of you for hearing us out. This is a critical bill, especially right now, to make sure that service providers, and specifically counties and tribes, have the necessary resources that they need to provide comprehensive care to people who are experiencing homelessness. We have a nation-leading partnership between the city of Minneapolis and Hennepin County and a number of service providers to transition people from homelessness into long-term and stable housing. But to do so, we need to make sure that there are a number of really important programs, in many cases that are already up and running, that continue to get the necessary funding. Programs like Avivo, programs like Homeward Bound, places where people can shut the door, take a breath, and then take the next step to lift themselves out of homelessness. And by the way, these are programs that are working. We are seeing really positive results in Hennepin County and in the city of Minneapolis in our ability to drive down unsheltered homelessness and drive up the number of people that we're transitioning into long-term and stable housing. We're presently producing 8.5 times the amount of deeply affordable housing that we were just about 7 years ago. And on top of that, we have some of the nation's leading affordable housing policy, but that's not enough. What we have found is that when you provide that kind of comprehensive care, when you truly wrap your arms around an individual, you can ultimately see success. And this money can go to fund, as I mentioned, low-barrier shelters, such as Avivo and Homeward Bound. It can provide 24/7 operations at existing shelters. It can provide shelter diversion programming and housing-focused case management, and it can assist with really critical new infrastructure that was created during the pandemic that's allowing the county to get people into permanent housing. Again, we've got a plan that is working. This is part of that recipe towards success and getting people into long-term and stable housing, and we would greatly appreciate your support. And thank you so much.
Thank you very much, and I really appreciate your coming to testify in the bill today.
Thank you.
Next, we have Commissioner Rena Moran.
Madam Chair,
Senator Abler.
will there be a chance to chat with the various testifiers if they can hang around?
I'm not sure if Mayor Fry can stay, but if you had a specific question for him, if he has time.
Oh,
Do you
yeah.
have-
I'm happy to answer now.
Oh, well, grab a chair then, Mr. Mayor.
Senator Abler.
Well, thank you, and twice in 2 days, that's pretty good. Anyway, so I I'm a co-author on this.
Thank you.
And I see a need, and you certainly have your hands full. So I appreciate you coming in to talk about this, and I don't envy your task. It's an important one and most daunting. As we go into trying to solve our deficit, you haven't been here for my return on investment comments, but perhaps you could be helpful in this as well as you talk to folks. The governor brought forward a budget based upon just our usual fiscal noting process. If we spend $1 million, but it's going to save 3, you got to spend the 1, you never get credit for the 3. The only way we get out of this to encourage the right kind of actions besides just cutting everything is to find a way to capture that 3 in our revenue discussions and so we can get the benefit. Otherwise, what we're going to do is not spend the 1 and then incur the 3, where the thing just crashes even more. And you're certainly, the city has the benefit of looking toward the value because you have your own budget. That means, and so if there's, as you interact with people on this topic and other ones that touch Minneapolis, if there's some way to help us judge the ROI, it's my intention to argue loud and long and frequently, Madam Chair, that we should be able to incorporate that. The state writes its own budget rules, but those rules currently bar us from considering the benefit. And there's study after study that shows that some of this stuff actually saves somebody some money, either the county.
Without a doubt.
And so, but in our interest as a state bucket, what we pass on to you is free to us, and what you get is free from us is free. So just, do you want to just, that's meant to encourage you in your work and help draw more partners into our solution.
Well,
Mayor Fry.
Absolutely. Madam Chair, Senator Abler, thank you so much for the comments. Put aside the benevolent reason to fund this bill for a second, recognizing that it is indeed benevolent. Getting people into long-term and stable housing is one of the most important things that we can do as a foundation from which they can rise. But putting all that aside, this is financially and fiscally smart. Why? Because it costs dramatically less to get someone from a shelter into a long-term and permanent home than it does to have them cycling through a despair of poverty where they're going to jail sometimes, they're going to hospital stays sometimes, they're cycling through shelters. That is 3 times more expensive, 3 times more expensive to the county and to the city and to the state than it is just to make sure that this transitional care is covered. So there is no doubt in my mind that, look, cities and counties frequently come and ask you all for money, and we thank you deeply when you say yes. This allows us to ask you for less money in the long run because we will not have as many people that are cycling through those conditions of hospital stays and shelter and sometimes tragically jail.
Senator Abler.
Thank you, Madam Chairman, and thank you, Mr. Mayor. Your first comment is like the tragic part of this conversation. We don't get to value benevolence. We don't get to value human, survival and the benefits on that. So it becomes all just a money game. And so while we, grieve about some of the human losses and challenges, at the end we got to pass a budget and didn't that matter about the families staying together, and didn't it matter about that they are around long enough to enjoy their grandkids and all that stuff? So thank you for reminding me about that. But so so I believe that it's 2 to 1, 3 to 1, but if you could help us with some math, we don't get to, I'm never going to win the argument second and third iteration away, but certainly if we did this, that's not going to happen. If we could get just, we're $6 billion light. And I'm not going to spend any time saying how we got there, but we are there, and the feds are even more broke than we are, and never mind how we got there. But here we are. And so with as you just, if you can think about that and help me with some math, with the good senator and my good commissioner, we can tackle this, and at the end, we can be better for it. So just if you can help with some specifics, not now, but just going forward from some of your city people and some of these various agencies where they see that you did this and that did not happen, and some really kind of solid ROI stuff. And then at the end, Mr. Mayor, and to the others, we're going to see the humanity come back that we so want. So thank you. Thank you, Madam Chair.
Mr. Mayor.
Madam
Right.
Chair, Senator, briefly, yes, we can get you that information. And the magic about the partnership that we have here is there's an ongoing day-to-day collaboration between Hennepin County, the City of Minneapolis, Ramsey, and St. Paul, where our staff and oftentimes public officials are talking to each other every single day to make sure that we're providing the right kind of service. And I'm certain that we can get you the numbers you need.
Thank you, and thank you again for coming today.
Thank you.
Commissioner Moran.
Good morning, Chair Whitlam and Senators. Thank you for hearing this important legislation and for the hard and important work that you are doing this session. I want to thank Senator Mohamed for being the chief author of this bill, and also to thank Senators Port, Abler, Champion, and Marty for co-authoring this important legislation. So I am Ramsey County Commissioner Rena Moran, and I'm also the vice chair of our Heading Home Ramsey Continuum of Care. The Continuum of Care is a federally mandated coalition that includes more than 100 partners who work together to end homelessness, including service providers and local governments like the City of St. Paul, Maplewood, and Ramsey County. So I am here today in support of Senate File 2124, which is a statewide bill bringing more funds to service providers and counties directly for this work. We see this bill as building off the Pathway Home legislation from 2023 and the important work and the funding done here. I'm going to do a quick sidebar as a former state representative. As I've heard Senator Abler say a few times here, that the legislature write the rules, right? And I know as a representative, I knew that and knew that clearly, right? We set the tone, we set the vision, and then we put the dollars towards that vision. And what I've learned as a Ramsey County Commissioner, that often those rules and those dollars come down to counties and cities, and we make your dreams come true. And so we want to continue to make your dreams come true. And so that is why this bill is so important. Your committee you have a tough but critical role to aid in the work to ensure that every Minnesotans have a safe and dignified place to call home. As many of you know, addressing our homeless crisis is key to addressing our state disparities. Safe, affordable housing allows Minnesotans to focus on work, education, children, and their health and well-being. Both Ramsey County and the City of St. Paul invested federal CARES and opera funds at the tone of $74 million into more affordable housing, but also used some of that funding to fund the front end of the homeless pipeline for emergency shelter beds and other critical housing support services, as well as the back end. And we are building 1,000 affordable housing units. We have heard similar statistics and commitments from our partners in Hennepin County, as you just heard today, and we are stepping up. But we need your continued help as counties and cities, because we are coming to a fiscal cliff. In Ramsey County, and one thing that we don't want to see happen is that the burden will fall on our taxpayers, our property taxpayers, who are in challenging times themselves. The timeline to build those units online is like a 3 to 5 year gap. And that gap, as well as the many challenges to getting this work done without directly supporting counties, is what we are asking you to help us with through this legislation. We need your help with funding to ensure the work we've done on the front end doesn't slide back as we wait for our affordable housing unit to come online. We also need your help to outline a process of county collaboration and capacity building that's in Section 3 of this bill. Current statistics shows that only about 1/3 of those served in Ramsey County shelters come from Ramsey County. I'll say that again. Only 1/3 of the services that we provide is coming from is to Ramsey County residents. We have others coming from across the state. And I know you're building the support in out of state, but this is the facts today. If we can make progress by funding Section 3, we can utilize best practice because we want to see this as a statewide initiative. We need this across the state. Shared experiences and lessons learned to support other counties across Minnesota and support their unsheltered residents stay where they are and drive in their community is and should be a priority. Of course, this bill also supports in Section 1, the work of our critical important providers without whom, in partnership, we couldn't make this positive impact we all need we all need to continue. And so when we talk about a continuum of care, it's that we're bringing over 100 partners together to look strategically about how we combat this place that we're in around homelessness, right? Because homelessness does not stand by itself. We are dealing with mental health. We're dealing with substance use disorder. We're dealing with whole families being displaced. And so we have to look at the whole continuum of care and do it in partnership so that we're also covering those gaps. And so in Section 2 of the bill is a direct assistance to allow counties to continue their leadership to address the homelessness crisis. Through the continuum of care, we would apply and prioritize the following needs in Ramsey County in the city of St. Paul. Increasing the amount of emergency shelter place and diversity among programs to better meet their demands. We'd like to maintain and expand extreme weather support to keep people out of the cold when shelters are full. And also the same in the summertime when it's really hot outside, because people also die in extreme heat. We want to expand navigation and support services to help people move from shelter to housing faster. Infrastructure planning to improve the housing referral system and to expand the diversity of housing programs for youth, families, and single adults, and improve accessibility. So I want to thank you for your time today. We do have staff here if you have any questions about our housing stability or heading home Ramsey County work. And again, I want to say just thank you so much for this work.
Thank you very much. Online, we have Reed Olson. If you can please state your name for the record and begin your testimony.
Yes, thank you, Madam Chair and committee members. Thanks for this opportunity to this morning to talk about important issues surrounding housing and homelessness. My name is Reed Olson. I am the Executive Director of the Nameless Coalition for the Homeless. We operate 2 low-barrier shelters in Bemidji, Minnesota, 1 emergency overnight shelter, and I'm in my office at our daytime drop-in center. I'm here today to speak in favor of Senate File 2124. I'm in favor as a shelter director who has seen the number of people seeking our services rise precipitously over the past 5 years. We now serve an increasingly diverse group of people. Too many people find their ways to our doors who suffer from persistent and untreated mental illness. Too many people find their ways to our doors that are elders in poor health. Our overnight shelter is a 26-bed shelter that routinely sees 30 to 35 people a night. Our day center can see up to 60, 65 people a day. At each site, we have 2 staff members working at any given time. And so this is quite a demand on our staff. I was in St. Paul yesterday for a Homeless Day on the Hill. I had to come back because of some obligations that I have. As I was driving down on Tuesday afternoon, I got a phone call from one of my staffers about an hour before his shift started that he was not going to be coming in and that he was going to be quitting because he felt that his mental health was suffering. Our staff works very hard in a very dynamic, very demanding atmosphere, and it really takes a toll on us. I'm also speaking in favor of this bill as a former Beltrami County Commissioner. Counties, as has been stated before, are on the front line in the fight against poverty and housing insecurity. These funds will allow counties to find solutions tailored to their constituents' specific needs, and it'll allow for collaboration between the many diverse 87 counties to find best practices. They can share their successes and caution each other against potential missteps. Minnesota needs to properly fund its shelter system statewide, but more importantly, we need to find and fund pathways to stability for our people. This bill does both. Please fund SF 2124 appropriately so that shelters and counties can continue to improve their response to the people experiencing housing insecurity in their communities. That's all I have. Thank you very much, and I'm happy to answer any questions you might have.
Thank you very much. And last, I have Rico Morales. Welcome to the committee, and please state your name for the record and begin your testimony.
Buenos dias, me llamo Ricardo Morales, me llamo Rico. Good morning, everyone. My name is Ricardo Morales. I go by Rico Morales as well. Thank you, Madam Chair and committee, for letting me come here to speak. We talked about the numbers and the data, and we have graphs and pictures to represent the data, but I here alone, sitting here, I represent the real humanity of this bill. The support that I've had in the past 13 years to have housing is life-changing for me. I was born into generational poverty, born into generational homelessness, and I've lived in Minnesota all of my life. I grew up here, and I love this place, and I love the support that we get, but we need more support as the system and the population is growing more and more. I have a background of childhood trauma, and that trauma added to my mental health issues and my behavioral issues. And the first time I ever had my own bed was when I turned 18 after I graduated from high school, and I did a year in jail. That was my first bed. So I felt comfortable, and it wasn't a horribly bad thing. But now as I've grown older, I've been chronically homeless in Hennepin County. Since 1992, I've lived in Minneapolis. I was chronically homeless, and I kept going through the jails, the treatment centers. I kept going through the shelters over and over and over. So when you talk about savings, housing is a savings to the Minnesota taxpayers. And I have been fully housed ever since 2012. I've been sober since January 29, 2011, completely. And these supportive services that this bill will help support is benefiting me personally. And when I am benefited, when I am changed and supported and growing more and more, I help more and more. The more I grow, the more I change, the more I can help. And I want to help people and organizations and nonprofits and governments find solutions to this homelessness issue. And Black and Brown, Indigenous, Native peoples are overly represented in our services. And we need the support for frontline staff, workers, frontline workers, staff, and support and pay for our staff at housing and shelter operations. That is harm reduction. And I just want to say that I was here last year to testify, and I'm here again this year. And I would like to see the support with these real numbers to benefit all Minnesotans who are living here, documented, undocumented. It doesn't matter. When we see one person sleeping outside, to me, that's a tragedy. And I have survivor guilt. I have been supported in permanent supportive housing since 2012, and I am a direct benefit of this work, and I really do come here with humility and gratitude and thank you that you have helped me to change my life. You have helped me to change my behavior. Recovery works, sobriety works, treatment, therapy, connections. We heal through relationships, and I want to have a relationship with all of my community members, my neighbors, my friends, my family. I want to have a relationship that's healthy, that's safe, that's appropriate. And that is, like, I don't even recognize the person I see in the mirror anymore. I just can't believe I'm sitting here talking to many of you honored and many of my colleagues here. I can't say enough about Hennepin County and the state of Minnesota and the support that they have given to change one life. And in the Talmud, when you change one life, you change the world entire. And I just want to say thank you for your support. Please consider deeply the humanity of this bill. Thank you.
Thank you very much for coming to share your story and helping us understand the impact that we can have. So, members, do you have any questions? Senator Kupec.
Thank you, Madam Chair. I'll be very quick. I realize we are up against the clock here. I just want to thank you for bringing this bill forward. I know our county, Clay County, also does these wraparound services, and I'll put that in contrast to my neighbor just to the west, who came up, is floating the idea of the way you deal with homelessness is you buy people a bus ticket and you send them somewhere else. So the wraparound services are the way forward, and you're a testament to that. So thank you, Senator Mohamed, for the bill. Just wanted to throw that up.
Any other comments? Senator Mohamed, any closing thoughts?
Thank you for hearing this again, Madam Chair. I know you're up against a really tight fiscal cliff, but hopefully we can do something about this. And I know it's as important to me as it is to you, so I appreciate you for hearing it.
Thank you. And yes, I hope so too. And we will lay Senate File 2124 as amended over for possible inclusion. And members, we have reached the end of our agenda and we are adjourned.